All right, welcome back, everyone, to the Deep Dive. We're diving into a particularly intricate area of medicine today. We're talking cardiology.
Oh, yeah.
You guys shared some pretty detailed medical notes with us.
Right.
And we are going to dig into Eisenmenger's syndrome
Yeah.
in the context of a VSD,
Okay.
a ventricular septal defect.
Sounds good.
So uh, I guess the mission here is to unpack this complex condition, understand how it's managed.
Okay.
And what I think is particularly interesting is how a seemingly simple problem in the heart, can set off this this kind of chain reaction leading to a complete reversal of blood flow.
Exactly. Yeah.
And then there are some very visible changes that we see in the body. So,
Yeah.
we talk about clubbing of the fingers and
Right.
toes.
Yeah.
It's a pretty powerful example of how interconnected our physiology is.
Yeah.
Right.
Absolutely. It is really striking how one thing can lead to another, and then another, and you end up with these findings. You sent us some detailed notes, and we're going to break down the key aspects of Eisenmenger syndrome related to a VSD. Think of it this way. We're going to explore how a simple initial plumbing issue in the heart can over time lead to a complete rerouting of the system.
Wow.
With really noticeable effects throughout the body.
Okay, let's dive in then.
Yeah.
So the notes describe a patient who has a diagnosis of Eisenmenger syndrome.
Okay.
And there were several key clinical findings that really jumped out at me.
Okay.
So we're talking about clubbing of the fingers and toes.
Right.
Central cyanosis.
Okay.
And I always think that's an interesting term.
Yeah.
Because cyanosis just means that there's a bluish tinge to the skin.
Yeah.
But central just means that it's kind of happening in the core of the body.
Exactly.
As opposed to the extremities.
It's not just your fingertips.
Exactly, yeah.
Yeah.
So, and then a loud and widely split-second heart sound and a right ventricular heave. So that's a pretty interesting finding too, because the right ventricular heave, and that's a palpable thing.
Right.
So that's something that you can feel on a physical exam.
Mm-hmm.
The doctor is actually feeling this lifting sensation on the chest, which tells us that right ventricle is
working hard.
really hard.
Yeah.
And that's often due to high pressure in the lungs.
Yeah.
Right?
Exactly. Yeah. Pulmonary hypertension.
Pulmonary hypertension. Okay.
Yeah.
So, interestingly, though, the notes also mention the absence of a significant heart murmur.
All right.
Which might seem a little bit
counterintuitive
if you're thinking about a heart defect.
Right.
So what's up with that?
Well, and that actually is a big clue. When you have an established Eisenmenger's, the murmur actually goes away.
Interesting.
And so, in a typical VSD, ventricular septal defect, which is basically just a hole between the two pumping chambers of the heart, the ventricles.
Okay.
You usually hear a murmur because you have the oxygen-rich blood from the high-pressure left ventricle leaking over into the lower pressure right ventricle. But in Eisenmenger's, the pressure in the pulmonary artery, which is the vessel that carries blood to the lungs, becomes so high, sometimes even higher than the pressure in the left ventricle, that the flow in blood reverses. So now, instead of going from left to right, it actually goes from right to left. And deoxygenated blood is flowing from the right to the left. And so once that happens, that murmur that you would typically hear, that left to right shunt murmur, it often diminishes or disappears entirely.
So it actually reverses.
It reverses.
Wow.
So the murmur goes away, and then you have other things that you start to see.
I see.
Like the cyanosis and all
that. So so to step back for a moment then.
Yeah.
How would you define Eisenmenger syndrome in a more formal way? What's the underlying process?
Sure. So Eisenmenger syndrome is essentially the reversal of that initial left to right blood flow in the heart.
Okay.
And it's all because of a congenital heart defect that wasn't addressed over time.
I see.
So the most common culprits are large uncorrected VSDs, ventricular septal defects, like in our case, and also atrial septal defects, so ASDs, which are holes between the upper chambers of the heart.
Right.
Less commonly, it can develop from a patent ductus arteriosus or a PDA, where a blood vessel connecting the aorta and the pulmonary artery just doesn't close after birth like it should.
I see.
And the key here is that long-standing increased blood flow to the lungs.
Right.
So this extra blood flow over years, what it does is it actually damages the small blood vessels in the lungs, causing them to thicken and narrow.
Wow.
And so this increased resistance in the lungs' blood vessels
Mm.
is what leads to pulmonary hypertension.
So okay, so it's the
So it's
thickening
a thickening.
of the vessel
And the
and the narrowing that causes the pressure to build up.
Exactly.
Okay.
That's what leads to the pulmonary hypertension.
Okay.
Yeah.
So and then it's this buildup of pressure in the pulmonary arteries that ultimately flips the direction of blood flow.
Exactly.
Okay.
So the right ventricle, now having to pump against the significantly increased pressure in the lungs,
Right.
it undergoes hypertrophy.
Okay.
So it gets bigger.
It gets bigger and stronger.
And stronger, trying to do its job.
Wow.
And that's what we feel as the right ventricular heave.
Oh, I see.
That palpable lift.
Okay.
And eventually the pressure in the right ventricle exceeds the pressure in the left ventricle.
Got it.
And like you said, deoxygenated blood from the right side of the heart starts crossing over through that VSD
Right.
into the left side and out into the systemic circulation.
Wow.
So it's bypassing the lungs where it would normally pick up oxygen.
Got it.
So that right to left shunt is what causes the central cyanosis, that bluish tinge to the skin,
Right.
and the hypoxemia, the low levels of oxygen in the blood that are so classic for Eisenmengers.
So the body's not getting enough oxygen because the blood isn't fully going through the lungs.
Exactly.
That's really a great explanation. So it really underscores why it's so important to address a VSD
Yes.
before it reaches this Eisenmenger stage.
Exactly.
So the notes mentioned
Yeah.
some specific reasons why a doctor might recommend surgical closure
Yeah.
of a VSD in someone who hasn't yet developed this syndrome.
Yeah.
So what are the major triggers for that decision?
So the primary reason is any significant
Okay.
left to right shunt.
Okay.
And the notes later specify this as a pulmonary to systemic blood flow ratio
Okay.
of 2.0 or greater, coupled with evidence of left ventricular dysfunction. So to put it simply, if twice as much blood is flowing to the lungs as to the rest of the body,
Got it.
and this extra work is starting to weaken the left ventricle, which is the heart's main pumping chamber,
Oh,
then closure is usually recommended.
I see.
Makes sense, right?
It does, yeah.
Another key indication is if a patient needs to undergo any other type of cardiac surgery,
Oh, okay.
then it's generally best to repair the VSD at the same time
To get it all done at once.
to avoid future complications.
Wow, okay.
The presence of endocarditis, which is an infection of the
Okay.
heart's inner lining, that's also a clear signal for surgery.
Oh, I see.
And finally, if the VSD is causing significant aortic regurgitation.
Okay.
So that's where the aortic valve doesn't close properly,
Right.
often because one of its leaflets is prolapsing
I see.
or bulging through the VSD.
Okay.
That also warrants surgical repair.
Okay. That makes perfect sense. So address the problem before it leads to more serious
Or it gets worse.
consequences. Exactly. Okay, so now let's think about our patient who already has Eisenmenger's.
Okay.
So imagine she needed surgery
Okay.
for something completely unrelated.
Right.
Let's say like an infected abscess.
Okay.
So what specific things would the medical team need to consider
Yeah.
beforehand, given her complex cardiac condition?
Oh, this is where a really careful team-based approach is absolutely essential.
Okay.
So the very first thing would be a detailed discussion with the cardiology specialists.
Makes sense.
You know, given her Eisenmenger's and the fact that the surgery involves an infection,
Right.
we need to be extremely careful about preventing infective endocarditis.
Okay.
So we would strictly follow current national guidelines.
Right.
For example, the NICE guidelines used in the UK for clinical practice
Okay.
regarding antibiotic prophylaxis before, during, and after the procedure.
Got it.
We would also need to really meticulously review her anticoagulation status. So some patients with Eisenmenger's may be on blood thinners for various reasons,
Okay.
and we'd need to manage that very carefully around the surgery.
I see.
The notes also mention that if the patient has polycythemia, which is a raised red blood cell count,
Okay.
which is common in folks with chronic low oxygen levels,
Right.
we'd want to check her clotting ability
Okay.
using a specific type of INR test called a citrated INR sample.
Okay.
And the reason for that is that the increased number of red blood cells can sometimes affect how the blood clots.
I see.
So we'd want to know her hematocrit,
Okay.
which is the percentage of red blood cells in her blood,
Right.
because very high levels can sometimes increase the risk of blood clots.
Wow. Okay, so So Eisenmenger's is clearly not just a static heart condition.
Right. It's dynamic.
It brings with it this whole host of potential problems.
Yes.
So what are some of the major complications that can arise
Okay.
in someone with Eisenmenger's?
Sadly, there are several serious complications we worry about. Okay. Ventricular failure is a big one, as that chamber of the heart is constantly working against those very high pressures in the lungs,
Right.
and eventually leading to fatigue and failure.
Got it.
We also have to be very mindful of the risk of paradoxical embolism.
Paradoxical embolism.
Yeah.
That sounds a little...
It's a little scary. Yeah. So normally if a blood clot forms in the veins,
Yeah.
it travels to the right side of the heart and then gets trapped in the lungs, causing a pulmonary embolism.
Okay.
But in Eisenmenger's, that right to left shunt creates a dangerous shortcut.
Oh, I see.
So a clot can cross over
bypass the lungs
into the systemic circulation and travel to the brain, causing a stroke, or to other vital organs, blocking their blood supply.
Wow.
So it's really a dangerous shortcut.
Right.
Infective endocarditis remains a persistent threat for these patients due to the abnormal blood flow.
Right.
Other complications can include hemoptysis, which is coughing up blood, which likely happens because the blood vessels in the lungs are under such high pressure and can become fragile.
I see.
And as we've discussed, that chronic hypoxemia, the low blood oxygen,
Right.
can lead to its own set of problems.
Okay, so in essence, Eisenmenger's creates a dangerous shortcut,
Right.
allowing clots to bypass the lungs and directly threaten vital organs.
Exactly. It's a very stark illustration
It is.
of that reversed physiology.
Wow. Okay, so the notes mention that our patient had an elevated JVP.
Okay.
So that's jugular venous pressure,
Right.
and which is basically a sign of increased pressure in the veins,
Yeah.
returning blood to the heart.
Right.
And she was experiencing worsening peripheral edema. So that's swelling in the legs and ankles.
Yeah.
And you interpreted this as likely indicating decompensated right-sided heart failure.
Yeah.
So can you explain how this all fits together and
Wow.
how it would be managed initially?
Sure. So the elevated JVP and peripheral edema are classic signs
Okay.
that the right ventricle is really struggling to pump blood effectively
Right.
against those high pulmonary pressures.
Okay.
And this leads to a backup of blood in the venous system,
Yep.
increasing the pressure and causing fluid to leak out into the tissues, which results in the swelling.
I see.
So the initial medical treatment would typically involve diuretics,
Okay.
which are medications that help the body get rid of excess fluid.
Got it.
And it's also absolutely crucial to get a very recent echocardiogram,
Right.
which is basically an ultrasound of the heart
Right.
to assess the function of that right ventricle
Okay.
and to measure the pressures in the pulmonary artery.
Got it.
And as we've emphasized, given the complexity of Eisenmenger's, a close discussion with the cardiology specialist is always essential to tailor that ongoing management plan.
Absolutely.
Yeah.
Yeah. It's a tricky
Yeah.
situation.
Yes.
Okay. So now let's switch focus a bit
Mm.
to a very visible sign mentioned in the notes.
Right.
Clubbing of the fingers and toes.
Yeah.
So it's quite a striking physical finding.
Yeah.
So what are the various potential causes?
Yeah.
It sounds like it's not something
You're right.
that's only seen
It's not just heart conditions.
in heart conditions.
Yeah.
It's almost like clubbing is the body's way of saying something's up
Right.
without being very specific
Yeah.
about the culprit.
Exactly.
Yeah, right.
You're absolutely right. So while clubbing is a well-recognized sign in cyanotic congenital heart disease,
Right.
Eisenmenger's,
Right.
where there's that chronic low oxygen in the blood,
Right.
it has a surprisingly wide range of potential causes,
Wow.
really highlighting the complexity of medical diagnosis.
Okay.
So within the heart, in addition to cyanotic congenital heart disease, subacute infective endocarditis
Okay.
can also lead to clubbing. However, it's also commonly associated with a variety of respiratory conditions, including lung cancer,
Oh, wow.
tuberculosis, bronchiectasis, where the airways are abnormally widened,
Okay.
cystic fibrosis, and interstitial lung diseases,
I see.
which are a group of conditions that affect the tissue around the air sacs in the lungs.
Got it.
Interestingly, certain GI problems,
Okay.
such as inflammatory bowel disease,
That's-
can also be a cause.
wow
And finally, in some instances, clubbing can simply be familial.
Oh, interesting.
Meaning it runs in families.
So there's no underlying medical problem.
Without any underlying medical issue.
Wow.
Yeah, so seeing clubbing in a patient really prompts a very broad investigation to determine what the root cause is.
Okay, so lots of possibility.
Lots of possibility.
The notes also mentioned a scar on the back of the patient's chest,
Okay.
which was identified as likely being from a lateral thoracotomy.
Right.
So, so what kinds of surgical procedures typically leave this type of scar? An incision made on the side of the chest.
So lateral thoracotomy, where the surgeon makes the incision between the ribs on the side of the chest, it's a common approach for a few types of thoracic surgeries.
Okay.
So for lung-related procedures, a lobectomy,
Okay.
the removal of a lobe of the lung,
Okay.
and a pneumonectomy,
Right.
the removal of the entire lung would both typically be done
Got it.
through this type of incision. While coarctation of the aorta,
Okay.
a narrowing of the main artery coming from the heart,
Right.
can sometimes be repaired using a lateral thoracotomy, the notes correctly suggest that this is less likely in this particular patient with Eisenmengers and a history of VSD.
Right. Okay.
Yeah.
And then the notes reveal the specific reason for this patient's scar, which was a pulmonary artery banding procedure she had in childhood.
All right.
So I haven't actually come across that term before.
Yeah.
So what exactly is pulmonary artery banding,
Right.
and why would it have been performed?
Sure. So pulmonary artery banding was a surgical procedure that was more commonly performed in infants and young children with large VSDs.
Okay.
And the main goal was to reduce the excessive amount of blood flowing to the lungs through the VSD.
Oh, okay.
So by placing a band around the main pulmonary artery,
Okay.
surgeons could create a controlled narrowing,
I see.
increasing the resistance to blood flow, and thereby decreasing the volume of blood, reaching those delicate blood vessels in the lungs. So essentially, it was a way to protect those vessels from the damage that can be caused by prolonged high blood flow and pressure, aiming to prevent the development of irreversible pulmonary hypertension, which is the very condition that leads to Eisenmengers.
Right.
So it was a preventative measure in the short term.
So it wasn't a definitive fix.
It wasn't a fix.
For the VSD itself.
Exactly, yeah. It was a palliative procedure, meaning that it was intended to improve symptoms and protect the lungs without fully correcting the underlying heart defect.
Oh, I see.
So the idea was often to delay the complete surgical repair of the VSD until the child was older and stronger, making the open heart surgery safer. However, as the notes point out, over the past couple of decades, the standard approach for large VSDs has really shifted towards early definitive intracardiac repair.
Okay.
So closing the hole completely in infancy or early childhood.
Right.
The outcomes with this early complete repair have generally been better.
I see.
And pulmonary artery banding is now much less commonly performed. It's a great example of how medical practice evolves.
It is.
As our understanding of disease and our surgical techniques improve.
Right.
What was once a common strategy is now largely replaced by a different approach based on new evidence and better outcomes.
That's really amazing. Yeah. Okay, so to really solidify our understanding, what are the key takeaways and the most important nuances to remember about Eisenmenger syndrome in the context of a VSD?
So the core concept is that Eisenmenger's is the unfortunate end result of a long-standing left-to-right shunt, reversing its flow due to the development of pulmonary hypertension.
Got it.
Clinically, these patients often experience shortness of breath and cyanosis even when they're resting, and they might need supplemental oxygen.
Okay.
The overt clubbing of the fingers and toes is a very visible clue.
Yeah.
It's also important to consider the underlying reasons for that initial VSD.
Okay.
And whether there are any associated congenital syndromes like Down syndrome, Edwards syndrome, or DeGeorge syndrome. So the high pressure in the lungs leads to signs like elevated jugular venous pressure and what we call functional tricuspid regurgitation, which can produce characteristic CV waves that the clinician might see during a physical exam. That parasternal heave, that lift that we feel on the chest, really suggests a right ventricle that's working under a lot of pressure.
Got it.
Interestingly, the loudness of the VSD murmur often actually decreases as the pulmonary hypertension gets worse and the shunt reverses. So in established Eisenmengers, You're more likely to hear that widely split-second heart sound with a very prominent pulmonary component.
Yep.
And it's absolutely critical to remember that that risk of infective endocarditis
All right.
remains a significant and ongoing concern for these patients.
Yeah.
When managing any heart failure symptoms that might arise,
Right.
diuretics are typically the first line of treatment
Okay.
to help with that fluid overload. For the pulmonary hypertension itself,
Yeah.
specialists might use medications that target the blood vessels in the lungs,
I see.
such as endothelin antagonists like bosentan, phosphodiesterase 5 inhibitors like sildenafil, and in more severe cases,
Yeah.
sometimes even continuous infusions of prostanoid medications. So it's a complex interplay of managing the symptoms and the underlying pulmonary hypertension.
And just to reiterate for clarity, the situations where closing of VSD
Right.
is strongly recommended before
Before it gets worse.
Eisenmenger's develops.
Yeah.
So we're talking significant shunt
Yeah.
that's also causing the left ventricle to weaken,
Right.
a prior history of endocarditis,
Right.
or if the patient needs surgery for another cardiac issue.
Correct.
Right. The notes also mentioned acute septal rupture.
Okay.
So that's a hole that suddenly appears in the heart wall after a heart attack
Right, right.
as another, though different cause of a VSD that would definitely require closure.
Definitely.
Right.
Yeah.
So, and when a doctor suspects a VSD,
Okay.
it's important to consider other heart conditions
Right.
that might present with similar findings.
Yes.
So, for instance, an atrial septal defect,
Mm.
a hole between the upper heart chambers, will also produce a split-second heart sound,
Right.
but it's typically described as wide and fixed,
Right.
meaning that the split doesn't change with breathing,
Right.
unlike the widely split sound we hear in VSD with Eisenmenger's.
Exactly.
At all.
So it's a subtle but important difference.
Right.
Mitral regurgitation, where blood leaks backward through the mitral valve,
Right.
usually causes a pansystolic murmur,
Right.
which is a murmur that lasts throughout the entire contraction of the heart.
Okay.
Loudest at the apex of the heart
Okay.
and radiating to the armpit, and it's often heard best when the patient breathes out.
Okay.
Tricuspid regurgitation, a similar leak,
Okay.
but across the tricuspid valve,
Right.
creates a pansystolic murmur at the lower left edge of the sternum,
Okay.
and it tends to get louder when the patient breathes in.
I see.
And pulmonary stenosis, a narrowing of the valve
Okay.
leading to the pulmonary artery,
Right.
causes an ejection systolic murmur.
Right.
So that's a whooshing sound heard during the ejection of blood in the pulmonary area of the chest.
Okay.
And this murmur also typically gets louder with inspiration.
So, so careful listening
Careful listening.
and examination can help differentiate
Yeah,
these conditions.
absolutely.
Wow. Okay, so you can really see how an initial structural issue in the heart
Right.
of VSD
Yeah.
can, over time, set off this whole sequence of changes
Absolutely.
that ultimately leads to Eisenmenger syndrome.
Yeah.
It's a really fascinating
It is fascinating.
and also very serious condition
Oh.
with effects throughout the entire body.
Absolutely. Understanding that progression from what might start as a seemingly simple shunt
Right.
to the complexities of Eisenmenger's really emphasizes just how important early diagnosis and timely intervention are for congenital heart defects.
Right.
Catching and correcting these issues early can prevent so many more serious problems down the line.
And on that note, considering the significant shift that we've seen from pulmonary artery banding to early complete repair of VSDs, it makes you wonder,
Yeah.
what other medical interventions that